aspects of the materials to revise to ensure information was clear, concise, and useful for healthcare professionals, parents, and caregivers. In the end, the 4 materials were finalized based on healthcare professionals' feedback and posted to the CDC website. The important thing to note about our process is the continued engagement with healthcare professionals in the field. Next slide, please. So this is your second self-knowledge check. Healthcare professionals from which practice setting were the most comfortable in treating a patient with MIS-C and communicating with caregivers? A, primary care settings, B, emergency care settings, C, urgent care settings, and D, inpatient settings. Next slide, please. So the providers that work in inpatient settings have the most confidence. So MIS-C Healthcare Professional Engagement Project surveyed providers in 4 practice settings and found that inpatient providers were the most comfortable in caring for and communicating with caregivers about MIS-C. Depending on the scenario, inpatient providers were 70 to 90% somewhat confident or very confident. Next slide, please. Now I will walk you through the 4 MIS-C materials developed through our healthcare professional engagement study. Next slide, please. The first handout highlights information to help healthcare professionals, particularly those working in outpatient settings, communicate the key symptoms of MIS-C and how to recognize it to parents and caregivers. As you can see, the resource was kept clear and concise so it could be shared with and easily understood by families. We found healthcare professionals appreciated the clarity and ease of understanding and said they would share the resource with their patients' families. One important aspect of this fact sheet was clearly showing the fever icon at the top of the symptoms chart. For a diagnosis of MIS-C, a fever plus 1 or more of the additional symptoms are needed to meet criteria. The intention was to show that a combination of symptoms was needed in order to try and decrease confusion on when patients should be referred for an evaluation for possible MIS-C. Next slide, please. This resource was developed based on our survey and interview findings, particularly our findings that less than 1/3 of healthcare professionals working in an outpatient setting were very confident in diagnosing MIS-C or talking with families about MIS-C diagnosis. Next slide, please. This resource can be found on CDC's MIS-C webpage and can be shared electronically or downloaded and printed. A QR code was also included so parents could scan and have it on their phone after a clinical visit. Next slide, please. Next, I will walk you through 2 of the resources developed for parents and outpatient healthcare professionals, highlighting what parents need to know. This first resource highlights key information parents and caregivers need to know about MIS-C. This material was designed to address the lack of confidence noted among outpatient healthcare professionals around having conversations with families about MIS-C diagnosis and treatment and addressing patients' questions related to MIS-C. The second resource on the right highlights key information parents need to know after MIS-C diagnosis, including what to expect while a child is receiving treatment in the hospital and after discharge from the hospital. Again, this resource was developed based on the needs of outpatient healthcare professionals, specifically the lack of confidence in speaking with families about what might happen if they're sent to the hospital and MIS-C follow-up care. Next slide, please. Both of these fact sheets were intended to educate parents and caregivers about 2 points in time when they would most likely have the highest level of uncertainty or stress: when concerned about a possible MIS-C diagnosis and after discharge from the hospital with a diagnosis of MIS-C. The materials were still intended for use with a healthcare professional to support the conversation at these points in time, so a parent or caregiver felt educated and understood. Next slide, please. These resources can also be found on CDC's MIS-C webpage, and a QR code is also included. Next slide, please. Each of these 3 materials were translated and made available in Spanish on the CDC MIS-C webpage. Next slide, please. So the 4th material we developed was designed to be a resource that could help healthcare professionals talk with parents about MIS-C and address key questions about the condition. This material went through a more in-depth round of revision following the online material testing survey because we received extensive feedback about the specific questions healthcare providers had received and those they would like help trying to address with families. Next slide, please. Shown here, the resource includes information to help address caregivers' key questions about MIS-C, including risk factors, incidence, symptoms, treatment during hospitalization, and follow-ups and long-term effects. Next slide, please. Unlike the previous 3 materials, this material exists on its own webpage. This is because we intended for this material to be used directly by healthcare professionals prior to or during conversations with parents and caregivers, but not necessarily shared with parents and caregivers. Also, this material was designed as a web page rather than a PDF, so it can be easily updated as new information becomes available. The web page location is noted in the bottom gray box. Next slide, please. To ensure healthcare professionals were made aware of these new resources, we specifically used communication channels mentioned by healthcare professionals during our phase 1 and phase 2 research. In addition, as mentioned, these materials were never intended to be direct-to-consumer materials or something a parent and caregiver would find on their own and use to diagnose their child. They were always intended for healthcare professionals to use on their own or with parents or caregivers. Therefore, we used a 2-pronged approach to dissemination. CDC's healthcare professionals channels included social media channels and networks like COCA and direct outreach to healthcare professional associations. We specifically targeted associations who were most likely to have members who treat pediatric and young adult populations. As a result, since September 2021, there have been over 1.5 million page views of the MISC material pages and over 50,000 downloads of the MISC PDF resources. We thank those organizations for the support of this important material. Now I will hand it over to Dr. Youssef.
Good afternoon, everyone. Thank you, Shayna. So I would like to cover 3 different topics that all relate to COVID-19 vaccination and MISC. Next slide, please. So first, I will discuss the CDC's interim clinical considerations for use of COVID-19 vaccines in people who have had MISC and have not yet been vaccinated. Then I will cover reporting of MISC in people who have received COVID-19 vaccine before onset of MISC. And then I will finish by discussing a study of COVID-19 vaccine effectiveness in preventing MISC. Next slide, please. So the CDC has provided interim clinical considerations for the use of COVID-19 vaccines in people with a history of MISC who have not yet been vaccinated. These clinical considerations can be found at the link at the bottom of this slide under the section titled COVID-19 vaccination and SARS-CoV-2 infection. Given the lack of data on the safety of COVID-19 vaccines in people with a history of MISC or MISA, a conversation between the patient, their guardians, and their clinical team or a specialist is strongly encouraged to assist with decisions about the use of COVID-19 vaccines. Several experts consider the benefits of COVID-19 vaccination, that is, reduced risk of severe disease, including potential recurrence of MISC after SARS-CoV-2 reinfection, to outweigh a theoretical risk of an MISC-like illness or the risk of myocarditis following COVID-19 vaccination for people who meet certain criteria. Next slide, please. These several experts suggest administering COVID-19 vaccine to persons with a history of MISC when all of the following criteria are met. 1, clinical recovery has been achieved, including return to normal cardiac function. 2, it has been 90 days or more since their diagnosis of MISC. 3, they are in an area of high or substantial community transmission of SARS-CoV-2 or otherwise have an increased risk for SARS-CoV-2 exposure and transmission. And 4, onset of MISC occurred before any COVID-19 vaccination. There are also additional factors when considering individual benefits and risks, and these may include increased personal risk of severe COVID-19, such as age or underlying conditions, and also timing of immunomodulatory therapies. ACIP's general best practice guidelines for immunization can be consulted for more information about that. Next slide, please. Now I'm going to discuss reporting of MISC in people who have received COVID-19 vaccine before onset of MISC. As part of the US COVID-19 vaccine safety monitoring plan, MIS after COVID-19 vaccination was pre-specified as an adverse event of special interest. because of the known association between SARS-CoV-2 infection and MIS. Vaccination providers are required to report MIS that occurs after COVID-19 vaccination to the Vaccine Adverse Event Reporting System, or VAERS, under the COVID-19 vaccine emergency use authorizations. VAERS is co-administered by CDC and the FDA. On the bottom right, I am showing an excerpt from VAERS listing what post-vaccination conditions are required to be reported under COVID-19 vaccine EUA. As you can see, MIS is included in that list. Adverse events after COVID-19 vaccination, including MIS, can be reported to VAERS at the link seen at the bottom of this slide, vaers.hhs.gov. Reports can be made by healthcare professionals, public health providers, or members of the public. Next slide, please. As part of its ongoing response to monitoring MIS-C, CDC conducted an investigation into MIS-C occurring after vaccination in persons aged 12 to 20 years from December 2020 through August 2021. This investigation looked at reports of potential MIS-C made to the CDC's MIS-C National Surveillance System, to VAERS, and through clinician or health department outreach to the CDC, including reports through the Clinical Immunization Safety Assessment Project, or CISA project, which provides clinical consultations on vaccine safety questions. This investigation identified 21 people with an illness meeting the CDC MIS-C case definition after COVID-19 vaccination, out of 21 million people aged 12 to 20 years who had received one or more doses of COVID-19 vaccine during the same time period. Thus, the investigation concluded that MIS-C after COVID-19 vaccination is rare, with an overall reporting rate of 1 case per million vaccinated people. Potential contribution of COVID-19 vaccination, if any, to the development of these MIS-C illnesses is unknown and could not be explored using surveillance data. And most of the people with MIS-C after COVID-19 vaccination in this investigation, 15 out of the 21 cases, or 71%, also had laboratory evidence of past or recent SARS-CoV-2 infection. When evaluating people with potential MIS-C after COVID-19 vaccination, antinucleocapsid antibody testing may be helpful to identify those who have had SARS-CoV-2 infection. This is because antinucleocapsid antibodies are indicative of past or recent SARS-CoV-2 infection, whereas anti-spike protein antibodies can be induced either by SARS-CoV-2 infection or by COVID-19 vaccination. Antinucleocapsid antibody testing would ideally be from a sample obtained before administration of intravenous immunoglobulin. Providers should report potential cases of MIS-C after vaccination to VAERS at the VAERS website. Next slide, please. Now I would like to focus on an evaluation of the effectiveness of Pfizer-BioNTech COVID-19 vaccine in preventing MIS-C among persons aged 12 to 18 years. This evaluation used a test-negative case control design by comparing the odds of antecedent full vaccination between MIS-C case patients and hospitalized controls without evidence of SARS-CoV-2 infection during July 1st through December 9th, 2021. Full vaccination was defined as receipt of 2 doses of Pfizer-BioNTech COVID-19 vaccine with receipt of the second dose 28 days or more before hospital admission. The 28-day time period was selected because a person is considered fully vaccinated against COVID-19 14 days or more after receipt of the second dose, and MIS-C generally occurs approximately 2 to 6 weeks after SARS-CoV-2 infection, with most cases occurring by the 4th week. Cases were persons with an illness meeting the CDC MIS-C case definition. There were 2 hospitalized control groups. The first control group was comprised of patients with 1 or more symptoms consistent with COVID-19, but with a negative result from a SARS-CoV-2 RT-PCR or antigen test. These were the test-negative controls. The second control group was comprised of patients without symptoms compatible with COVID-19 who might or might not have received SARS-CoV-2 testing. These were the syndrome negative controls. Eligible controls were matched to case patients by site, age group, which were 12 to 15 years and 16 to 18 years, and case patient hospitalization date within plus or minus approximately 3 weeks. The evaluation included 102 MIS-C case patients and 101 hospital